Okay, welcome. On behalf of everyone here at the Center for Brain Health, we welcome you to this Frontiers of Brain Health lecture today. So this is the series where we really do take a deeper dive into some of the most exciting new developments in brain research. My name is Lori Cook, and I serve as the Director of Clinical Research here at the Center for Brain Health. And we're delighted to have both an in-person audience as well as our live virtual audience. So just a quick note, we are going to reserve some time at the end of the talk today for some Q&A. So we'll be taking questions both from the live audience as well as our virtual audience. So for those of you who are online, we encourage you to be thinking of your questions, and as you have them, feel free to put them into the Q&A function on Zoom, and we'll get to as many as we can at the end. And just a quick note for those of you who are new, who maybe aren't familiar with the Center for Brain Health, we are a cognitive neuroscience research center here at the University of Texas at Dallas. And we've really dedicated the past 3 decades to exploring neuroplasticity and the brain's amazing lifelong potential to get stronger and work better. And today's talk is going to be a wonderful addition to this. So before we introduce our speaker, please allow me to bring up one of our esteemed collaborators to share more about our speaker for today. This is Dr. Mark D'Esposito, and he is actually our Carol Heller Brain Health Project co-leader, serves as a distinguished professor of neuroscience and psychology at the University of California, Berkeley. Dr. D'Esposito.
Thank you so much. In case it doesn't happen again in the near future, I want to congratulate you all on your World Series win and to the Texas Rangers. So we've got that on video record so we can, in the future, look back on it. Exciting. All of San Francisco was rooting for you. So it's really a pleasure to introduce our speaker today, Dr. Iftach Dolev. Gotten to know him over time, and he originally got his PhD and postdoc as a neuroscientist at Tel-Aviv University, and then subsequently after that co-founded a company called QuantalX, which you're going to hear, QuantalX Neuroscience, which you're going to hear about, which has been almost 10 years now, right? I believe, and so I'm not going to sort of spoil the punchline as to what the device is, but it's a medical technology company that he's going to tell you about a device that they've invented and developed using transcranial magnetic and EEG technology that really allows one to sort of develop and measure biomarkers in the brain that can track both brain health and also sort of track and guide neurological disorders. It's quite extremely exciting tool. It's already gotten sort of some FDA sort of excitement, and hopefully it will be approved soon. And we're excited because we're going to collaborate on a project through the BrainHealth project. We're going to be able to utilize this device and collect information about brain health along with all the other brain health information. I think it's going to be an amazing sort of complement to what we're doing, and hopefully it will really be a game changer for everyone in terms of brain health. And so for those of you in the audience that are scientists in the center that may be interested, hopefully you'll learn today about what it is that QuantalX has been able to put together and how it can be used, and hopefully you'll want to participate in the project as well. So we're going to hear an overview now, and then we'll have time afterwards for questions. So really exciting talk. Looking forward to hearing you talk. So you're not going to...
I have this. Thanks. Just a second. So hi, everyone. I'm really excited to be here today. So thank you, Professor D'Esposito, and of course, thank you, Professor Chapman, for inviting me here to present our work in the last 10 years. And just to save some time, I'd like immediately to go forward with the presentation, especially following Professor Despacito's background introduction. So I'm a neuroscientist. In the last 10 years, I've been, since we founded a company called QuantalX. And in QuantalX, we developed a system called Delphi, and I'll explain exactly the system in a second. The mission that brought us to develop the system was actually the title of this lecture, which is to bridge the enormous gap that exists today between clinical practice, what exists today in neurological clinical practice, and the knowledge that we have in neuroscientific research. Of course, we don't know everything about neuroscience and neuroscientific research, but we know enough, and we know a lot. And when it comes to clinical practice, the tools that neurologists use, neurologists or brain specialists like psychiatrists, of course, as well, are very, very limited. And our mission was to develop a tool that will enable physicians, care providers, to evaluate brain health, to diagnose brain health, to monitor brain health. And I think this is really aligned with this center. And this is why it's very exciting to be here and present you with what we do. So just as a background, I'll give you a brief background of how we see this gap and exactly where this gap exists. And it's mainly in the world of, or in the field so I think when we talk about brain aging in general, or brain degenerative disorders, of course, as you know, it's mainly dementia, different kinds of dementia like Alzheimer's disease, vascular dementia, stroke, of course. Thanks. Which basically makes it the biggest world, not even economic, but biggest medical unmet need. Of course, exactly as seen in the movie before I started my talk, it's a pandemic, and it's growing as world, of course, ages, and there are more people that age normally healthy above the age of 100. And so these brain degenerative disorders, age-related disorders, are becoming more and more prevalent. Just to set up the numbers, not even economically, but the numbers, if you take in the US all cancer cases together, the prevalence of brain disorders is over 40 times higher than all cancer cases together annually. And it just keep on growing. So there is a huge, huge unmet medical need here. So I want to emphasize, why is there such a huge need? When we look at the patient journey, or what exists today, actually the physician that detects most brain disorders is actually the primary care physician. He's the one who knows you, or he or she is the physician who knows you, knows to detect these brain disorders. Based on his experience, he doesn't really have any tools. So based on experience, as a cognitive assessment, if he might use them. And then the patient will be sent to a neurologist or a brain specialist, maybe even a psychiatrist. It takes an average in the US to reach a neurologist about 6 months. Still, in both physicians, both the primary care physician and the brain specialist and neurologist, they don't really in their clinical office have any tools to evaluate brain health. They can diagnose a disease when a disease is already prevalent, if there is a cognitive abnormality already. But when there is an abnormality in brain health, which we know that happens at least 10 years prior to any kind of phenotypic cognitive decline in the case of dementia, they can't really diagnose it. They don't have any tools to diagnose it. So they might refer to an MRI, which they usually don't have in their clinic, which is also very limited in the information that it gives, especially in early stages. But still, this late diagnosis and misdiagnosis lead to very high percentage of late, or undiagnosed brain disorders, especially brain degenerative disorders, of course. The amazing thing is that it is well known and established, and I think this is the common understanding that led this institute to be such an important institute, is that most brain degenerative disorders, age-related disorders, can be prevented or at least delayed significantly if detected early enough, as quoted here. And if we look at this graph for a second, this published graph, you see normal aging in green and abnormal aging in red. And you can see that actually today, those brain degenerative disorders are only diagnosed either by imaging or later on even by cognitive assessment, when actually the challenge should be, or the effort should be, to diagnose them very early in the deterioration in order to be able to delay, or even in many, many cases, to prevent this deterioration. And this was exactly what led us to our development. When we look at what exists today in clinical practice, we can divide it into three, basically. Imaging technologies like MRI, CT scans. The clinical ones are focused on brain structure, not brain function. So they can only detect things that are observable in changes in structure. Function always exceeds, is always earlier, much earlier than structure. And of course, imaging still very expensive, not very accessible. So some physicians might use cognitive assessment, mini-mental, MoCA, cognitive assessment, computerized cognitive assessment, if they might still very subjective, very indirect, and again, can only detect very late progressed diseases. And the functional ones, like EEG, for example, and I added all kinds of new technologies there, because these technologies have one thing in common. First of all, one of the physicians recently that I talked with, I mentioned this yesterday at the dinner that we had, mentioned that like 30 years ago, they used a lot of EEG in their clinic. Today, the clinical use of EEG is just decreasing and decreasing, while the use of EEG under all kind of technological companies that try to develop new tools based on EEG is just increasing and increasing. But EEG by itself, it's a method that records brain noise. Brain is a very noisy organ. Very hard to understand something out of this noise that the brain creates all the time. So the ability to use EEG for clinical diagnosis, aside from epilepsy, of course, is quite limited. However, the idea of EEG is based on brain physiology. And when we look at brain physiology, this is exactly emphasizes the gap. Brain physiology or electrophysiology has been around for at least the last 40 years, 4 decades, maybe even more. And today it's considered in neuroscientific research the most used technique, the most objective and direct way to evaluate, to monitor brain health, brain performance, the effects of a specific drug or any kind of manipulation on the brain. You can use electrophysiology to determine this. And electrophysiology can be in different levels, from EEG that I mentioned, non-invasive, recording brain noise, to invasive electrodes that measure either local field potential, used very frequently in research, of course, mainly, of course, in animal models. It's quite hard to do it on humans still, but gives a lot of valuable information, field potentials, and of course, single unit patch clamp or techniques like this that increase the resolution of our ability as scientists to understand brain function, evaluate brain function, monitor brain function in healthy as well as in disorders in a very precise and direct manner. However, these tools don't exist in clinical setting. There are no actual tools that are approved and used to evaluate and monitor and diagnose or enable the physician to diagnose brain degenerative abnormalities using electrophysiology. Just a glance into the literature. It is well known, and actually I want to mention a paper that was published yesterday in Nature Communication that actually focused on what's known to be part of prodromal Alzheimer's disease, early stages of Alzheimer's disease, and mild cognitive impairment, the epileptic-like activity in hippocampal areas, in medial prefrontal cortex, which is known to be associated with early deterioration to Alzheimer's disease in very early stages. So electrophysiologically, you can detect these early abnormalities, and you can even, in this paper, they talk about the mechanism and why some people with Alzheimer's disease pathology like amyloid and phosphorylated tau will not develop Alzheimer or Alzheimer dementia, or dementia by definition. So in this paper they focus on the mechanism why those people will not develop Alzheimer and what should be done, and what can be done in early stages of specifically of early Alzheimer or mild cognitive impairment. There are also evidence of in Parkinson's disease, the low dopamine that increases spikes and the higher frequencies of between up to 10 hertz of activity in the brain of individuals, of people, of humans, of course. So electrophysiology by itself is a very powerful tool to understand, to study, to evaluate brain function and brain health. And in that sense, I want just to correlate brain to another organ, which you all know about, which is the heart, of course. And usually when you ask a neurologist, especially neurologists in the field of vascular neurology, which is very common, of course, where is neurology headed? They will probably say, look 30, 40 years back in cardiology, and you'll know where neurology is headed. And there is a reason for this. Those two organs are quite connected, of course. And when you look at EKG or on cardiac cardiology or heart disease, there is EKG. EKG is used, of course, you can take a picture. You can have a CT scan or an X-ray of the heart, so you'll know it's there. But it doesn't really mean whether it functions normally or abnormally. So there is a screening tool called an EKG, widely used, of course, by any primary care physician before it's the first step in the patient journey on the way to the cardiologist. But the first step is running an EKG. You feel chest pain, you run an EKG that determines whether it's actually something cardiac relevant or stress, digestive, no further referrals are needed, you can go back home. When it comes to the brain, which is, again, like the heart, a functional organ, a physiological organ, there are no such tools, of course, much more complicated in the physiology level than the heart, but then we don't have any clinical available tools to evaluate the brain. And this is exactly what led us to develop a system which enables a direct and functional way to evaluate the brain in an accessible way. It can be used by any physician to monitor your brain health, and if there is any kind of abnormality, detect it at the very early stages of deterioration. So I want to introduce you with the Delphi MD technology. This is how the device looks. Hopefully you'll be able to see it in real life very soon here. The device can be used in any clinical setting. It's automatic. It doesn't require any participation from the patient side. So it's not a cognitive assignment, although it does give values of changes related to cognitive abilities. It doesn't require any specific training from the technician. You simply place it above the patient's head, and the stimulation starts. It combines, exactly as Professor Despacito explained at the beginning, two basic technologies of magnetic stimulation and an EEG. So we took the capabilities of an EEG as a system, as a technology, which does have a lot of capabilities recording electrical or neurophysiological activity, but we evoke a potential response by stimulating in high resolution magnetic stimulation over 6 hubs over the brain network. So we developed this, as you see the white thing there above the patient's head. Oh, you don't see. So it's a magnetic coil, magnetic stimulator probe in a size and a weight of an iPhone that stimulates the brain automatically over 6 hubs over the brain network. And just to explain it in simple words, it's like looking at a 200,000 story building. If you want to understand the electricity in this building, you can look at their MRI or CT scan, which mainly means you look at the sketch of the electrician, the electricity circuits in the building, and you know that the circuits are there. There are all the connections. You don't really understand whether those connections work properly. If you run an electrical signal in this building, whether it runs as it should run, reaches all the floors as they should, and whether this electricity, when it reaches a certain floor, does what it needs to do. When we compare it or parallel it to brain function, when you look at the brain, you can do an MRI or a CT scan, which is used today in a clinical setting. You see, you understand brain structure, but not really brain function, which is the thing really to understand if you want to diagnose and evaluate early changes that lead later on to any kind of brain disorder. In order to understand this, if we, again, compare it to a building, what we do, we stimulate this building in 6 floors, different floors in the building, and we look at the signal as it runs through the building, synchronizes these responses and these stimulations, and look at the ability of the network in terms of connectivity, coherence, and of course brain plasticity, or in this case building plasticity, but brain plasticity, which means the ability of the brain network to change the ratio between excitation and inhibition, a very important feature of brain function which exceeds, which of course decreases with age and specifically changes in pathological states, as I'll show you in a second. So just the principle of operation of the system, as you can see here. The probe, as I mentioned, in the size and the weight of an iPhone, stimulates the brain automatically over 6 hubs over the brain network. Hardly felt. Most people can be drowsy while we do the procedure. No participation is needed, and evokes a potential of response. Very high in signal-to-noise ratio. That's why it can be used in any clinical setting, and that's also why many physicians, neurologists who work with the system, call it the brain EKG, because it looks a bit like it. It's a very significant signature of response, robust in healthy individuals, but changes significantly in any kind of pathological deterioration very early in the deterioration process. And a report is generated in real time, automatically, in about 25 minutes from the beginning of the process, stating whether the brain is healthy to its age group, unhealthy, or whether there are any kind of abnormalities. What are those abnormalities associated with? Vascular changes, white matter hyperintensities, medial temporal atrophy, specific pathological changes that are relevant to specific brain diseases or disorders, of course. Exactly like in this case, as you can see in the report, a bit like a blood test. Green means you are within normal range. Red means outside normal range. And of course, a concluding remark, concluding statement, your brain is healthy to your age, or your brain is unhealthy to your age because this and that. Depends on the pathology. So this is the principle of operation of the system. And if we go back for a second to the patient journey, basically using a device like this, by the neurologist or even by the primary care physician, can actually enable for the first time a very easy way to monitor and evaluate brain health and help the physician diagnose the early occurrence of any kind of brain degenerative disorders that will eventually lead to either dementia, stroke, or other brain disorders. Now, we were not the first one, of course, to combine this stimulation with recording using EEG. This is a well-established method that is not used clinically in any way because it's quite complex. What we did was combine these technologies in one box with our own software and algorithm to analyze the data and enabled it to be accessible to any kind of physician, to any physician in the clinical practice, evaluating this signature of response, which is, again, very robust, can change significantly, and give a lot of information regarding brain connectome, connectivity, coherence, and again, the change between these amplitudes which reflect short-term plasticity. Again, plasticity, as you know, you probably know the terms long-term plasticity, can be from the early stages of short-term plasticity, which reflects changes in excitation, inhibition, and in the long term, these changes are reflected as structural changes at the end. There's long-term plasticity. So plasticity can scientifically be called long-term potentiation, short-term potentiation, depression. It can be good, it can be bad, but basically it means the ability of the brain to change its function and structure later on. And this is a very significant, very important feature, physiological feature, that the system is able to detect immediately. So over the years, we've been able to collect a lot of data. The system was granted as a breakthrough designation twice already. Like about 3 years ago, the system was granted as a breakthrough designation by the FDA as a tool for the early diagnosis of people at risk for stroke and early stages of dementia, meaning that those people don't have a cognitive impairment yet. They don't have any structural abnormalities seen like this in MRI, but the system physiologically is able to detect that these people are at risk, at high risk for developing dementia, specifically Alzheimer's disease, vascular dementia, Lewy body disease, and we'll get to it in a second. And recently, a few months ago, the system was also granted as a breakthrough designation to predict patients who will benefit from a shunt implant, a VPS. Surgery, in this case, in people diagnosed with what's called normal pressure hydrocephalus, NPH, and we get to it hopefully later on, if we'll have time. So I just want to show you some of the data that we gathered. Of course, we gathered data from thousands of people all over the world, mainly in the US, also in Israel, where the R&D of the company is still stated. And I want to go through some of the results we have to show you how the system performs and the validation of the study. So here, this study that was published already, of course, compared 4 groups of patients. Dementia, people with dementia, diagnosed with dementia. On the other opposite side, healthy individuals, and the very interesting middle groups, one with diagnosed with mild cognitive impairment, and the most important group, in my perspective, is the subjective cognitive decline. Those, like almost anyone that comes to the primary care or to the neurologist complaining of a cognitive decline, which basically they don't really have any cognitive abnormality. Out of this, in this study, first of all, we compared Delphi, which is network physiology, Delphi ability to detect abnormalities compared to cognitive assessment, which is, of course, the least sensitive to detect abnormalities, and to gray matter changes and white matter changes. And of course, Delphi correlates very highly, very nicely with white matter changes. It's a bit even more sensitive to detect early brain changes, physiological changes, than any kind of imaging tool today. And we did show in this study that about 30%, 28% of people who complain of a cognitive decline but don't have any cognitive decline actually in the test that the physician either interview or cognitive assessment using Minimental, MoCA, or cognitive computerized test. In this test, they don't show any abnormality, but using Delphi, we show that almost 30% of them already have significant abnormalities, predicting early occurrence of degenerative disorder, specifically in mild cognitive impairment and leading to dementia. The second study, which is actually the first study, was published using this system that led the system to be granted as a breakthrough designation by the FDA, also compared 4 groups. First of all, normal aging between the age of 25 to 45, a bit older, 50 to 70, and 2 parallel groups, over 70 compared to over 70 diagnosed with early dementia. And you can see in this data, it's quite hard maybe to follow all this data, so I'll guide you through the graphs. You can see that the red group, which is diagnosed with mild dementia or MCI, can be differentiated from the rest of the groups significantly, specifically on the basis of evaluating brain network plasticity, which I mentioned before. So dementia can be characterized also in the middle graph, in the triangle. You can see the connectivity maps. And dementia can be differentiated, diagnosed using the system by 2 specific parameters. On the left, you see the images of the map of brain plasticity. Blue means high plasticity, red or yellow means lower plasticity. And using Delphi, we can differentiate normal plasticity from abnormal plasticity in early dementia, and also using the measures of brain network connectivity, as can be seen here in these graphs. The system can also be used for differentiating which kind of dementia, comparing specifically Lewy body dementia compared to mild Alzheimer. Of course, this is a study that was done by one of the facilities that work with the system. I have a real hard time understanding the term mild Alzheimer. Alzheimer, by definition, is not really mild, but that means, and this also shows you or teaches you regarding the enormous gap that exists. Alzheimer, by definition, when it's diagnosed, is not mild anymore. It's been around for at least 10 years, maybe even 20, since it began the physiological deterioration that was eventually diagnosed as Alzheimer. But here in this work, they refer it as mild Alzheimer, which means it's early after the diagnosis of Alzheimer, and stable MCI, which means mild cognitive impairment that did not deteriorate in the last 2 years from the diagnosis. So you can see that using Delphi, you can actually differentiate when somebody shows cognitive abnormality, whether they suffer specifically from Alzheimer or Lewy body, or they do suffer from cognitive impairment, but it's not dementia related, it's not degenerative. Here, it's a study focused on, so I give you a glance of specific indications. So here, this indication focuses specifically on a stroke or a TIA specifically, mostly, and mild traumatic brain injuries. And not only that the system is very sensitive for detecting these abnormalities, I think the most important graph or interesting graph here is the graph on the right. What we did here, we compared the DTI in an MRI, DTI, a fractional anisotropy of the network of specific white matter fibers. We compared in an MRI, compared to the prediction of the damage of specific, or the severity of damage and the damage in specific white matter fibers using Delphi. So we had the true fractional anisotropy evaluated in DTI compared to the prediction of changes in specific white matter bundles and the damage in these fibers using Delphi. And you can see the very nice correlation. So Delphi basically not only can determine and diagnose and evaluate, but also be quite precise in determining which white matter fibers are damaged and what is the severity of the damage. And if we place in stroke patients these results, and I always, as a neuroscientist, prefer to show data and not images, but I understand that one image is better than 1,000 words, of course, so we can correlate this or superimpose the data on the image, on the MRI image of a specific patient. I can show you images of somebody that under a 75-year-old patient that underwent a stroke, CVA. In this case, and these maps are plasticity maps. So again, blue means very high plasticity in our analysis. Red means very, very low plasticity. Plasticity is something that changes throughout life. And in about 70 years old, you should see something like a yellowish picture here. The interesting thing is that using Delphi, you can actually evaluate during rehabilitation. It doesn't really matter if it's real intervention or if it's the rehabilitation is purely time that passed through the event, through the stroke, from the stroke. But here you can see that 5 days after the stroke, you see the damaged area. The red area that shows significant damage in the right hemisphere, the motor area, the occipital areas. And in the, I'll jump to the 65 days following the stroke. You can see that there is a stable picture here with abnormal plasticity, very low plasticity, much slower than what we saw 5 days after the stroke, but still a stable picture. Why did I leave the middle picture or middle image outside until now? Because I think this image is the most interesting image here. And I think that this tells all the story, first around Delphi and also about brain function. And I'll explain. Our brain is a physiological organ. It's a functioning organ. It has to find equilibrium, steady state of activity. And this, I think, leads a lot of the misunderstanding of the brain, especially in pathological states, and a lot of what we provide with Delphi. Here you can see that the picture shows significant, the middle image, instability of the network, showing very low plasticity in damaged area and very, very high plasticity in frontal areas and in different areas. High plasticity which is not normal to a 75-year-old person, which means there is a point in which the brain is unstable. The brain is looking for a steady state, a new equilibrium. And when you look on any intervention or even brain damage, the first thing that happens in the brain is that the brain is looking for a new steady state, a new equilibrium. This is what it aspires to get to. It might take a year, it might take a week, it depends on the age, on the experience. It's very personalized, this process, but at the end, the brain will reach either the former plasticity map or the former steady state of activity or a new equilibrium of steady state of activity. And this is the process that everybody goes through any kind of brain change. In this case, it's a traumatic brain injury or a stroke, and you can see that 35 days after the stroke, you see an unstable picture that shows exactly that there are high plasticity areas and very low plasticity. This picture can be seen in any kind of rehabilitation process, but the personalization is very important because it changes dramatically. Some pictures show this instability a week after the event. Some show this instability 3 months after the event. It's highly personalized in order to optimal the rehabilitation process and the treatment that should be given to this patient, you have to look at this picture and personalize the treatment that you prescribe to these patients. Specifically, in the middle picture, you understand that there are areas in the brain which shows very high plasticity, which means these areas are more prone to change. These areas should be rehabilitated, interacted in any way, because there is a very high percentage that these areas will be affected by any kind of intervention. Going forward to another pathology, am I good in time? I'm not sure how much time I have left.
10 minutes.
Okay. So I'll have two more pathologies and then I'll stop. When we look at Parkinson's disease, this is another study that was published. So we measured healthy individuals compared to early Parkinson patients, and you can see that Parkinson patients can be diagnosed and differentiated from healthy individuals using Delphi based not on plasticity. If you see that plasticity map is not different in healthy controls and Parkinson patients opposed to what happens in dementia and in Alzheimer's. But in Parkinson's disease, you see that WFA wins waveform adherence, which means a comparison of the patient's this evoked response, the EKG of the brain of these patients compared to an average age-dependent measure of the age dependent of this patient, of course. So a comparison of the response of the patient to an average response, normal response. This is what's called a waveform adherence. So Parkinson patients are differentiated from healthy individuals in the level of waveform adherence, cortical excitability, and the most important feature or measure in Parkinson patients is the interhemispheric connectivity, which not only can diagnose which patients have early Parkinson, but it can also be used to subtype which Parkinson disease patients are they, whether they are tremor dominant or the more severe cases of Parkinson, the PIGD patients. And the last indication that I want to emphasize is the NPH that I mentioned at the beginning. NPH, normal pressure hydrocephalus. This is an indication that the system was granted as a breakthrough designation by the FDA only 2 months ago. And you can see actually the signature of response, normal with the individuals, again, the EKG of the brain, healthy individual in green, and the NPH patients that shows a shift in the response, very robust, very diagnostic for NPH. And today NPH, I'll just briefly, for those of you who don't really didn't hear the term like I didn't hear it before, NPH is a dementia with a mobility abnormality, movement disorder, very hard to diagnose. So the only way to diagnose it today is following an MRI that shows an enlargement of the ventricles, but nothing else besides this, and a cognitive impairment. You have a mobility test, up and go test, before and after a TAP test, before and after CSF withdrawal from the spine. For elderly population, it's quite complicated. It's not something physicians like to do very much. But if they are diagnosed, they show an improvement in the up and go test, in the mobility following the withdrawal of CSF from the spine, they undergo a shunt implant, a VPS surgery. The shunt implant for NPH patients is very, very productive. It's very beneficial. In about 90% of cases, it actually prevents a further delay, or at least delays the abnormality, the degenerative disorder, in even a few years, up to 6 or 7 years. So it's very important to diagnose these patients, but the diagnosis procedure is very, very complicated, and most physicians don't really like to do it. Using Delphi, we were able to show that if you look at the graph on the left, CSF TAP test, the diagnosis done today, shows a sensitivity of about 77% and a specificity of 67% in the accuracy of diagnosing NPH and predicting patients who will benefit from a shunt implant. Using Delphi, we were able to show, and this is why the system was granted as a breakthrough designation for the second time from the FDA, a sensitivity of over 86% and a perfect specificity to determine who will benefit from a shunt implant. And altogether, there is a huge potential for using this system because basically I just gave you a glance of specific diagnostic indications for brain disorders, because this is what the world knows how to relate to. This is what we can present and publish papers for. But at the end, it's all an issue of bridging the gap. Brain health. Brain health is the issue here. And this system, when somebody is already diagnosed with dementia, with Alzheimer, is less relevant maybe to monitor the effects of a specific treatment. It might be relevant for a specific drug, an intervention, a rehabilitation following stroke, but the real value of the system is the early diagnosis, the monitoring, the evaluation of brain health. And I think this is well understood today, even based on even Medicare, that requires every year that everybody under Medicare coverage will have a brain health evaluation. Nobody does it, but they understand it's needed to diagnose those who will deteriorate. However, they understand it, but there are no tools to do it. This is why the system like this is very important, and this is why I think the most important center in the world that focuses on brain health is a very important center that should be everywhere in the world. Everybody should know of the activity that is done here, which is amazing, because this is exactly what is needed in the world of neurology, in the world of brain health in general. And I think for us, as the company that developed Delphi, the first system that enables an accessible and affordable way to evaluate brain health, there is no better way to be in than actually the center that owns the trademark for brain health, which is here, of course. So thank you very much, and I'll be happy to answer any questions you have. Thank you very much.
So with the FDA, what are they classing this device as? And are you looking for approval as a new device, or is it a clearance adjacent to some other device already in the market?
That's a good question. So we have many discussions with the FDA, actually. So it's a new device. It's a de novo, of course. It's a whole new device. Actually, the FDA understands there is a huge amount of data around EEG, TMS, the combination of both. Nobody actually approached and developed a system like we did. So they understand it. And although they granted the system twice as a breakthrough designation for diagnosing people at risk for stroke, dementia, and now NPH, our approval will be even more general, to enable any physician to get physiological measures of brain activity. And this is actually what they guided us. We started from actually dementia and comparing what we do to an MRI. But actually the FDA understands it and understand this is a tool that needs to be approved as a general tool that will enable any physician to have real physiological measures and understand the brain.
Incredible. I mean, it's so exciting for us to think about being able to partner and understand the technology. As you know, thank you for just bringing it to our attention, and to Dr. Dallas Hack and Mark to help bring this together. As a research center, since we don't have neurologists, to do this, do you have to have a neurologist in place to be able to do it?
So, no, in place, no. We can do it in every, it's also the way that we use it today. We don't have neurologists, of course. For research, of course, anyone can use it. The data is analyzed automatically. We can analyze the data further with our technicians, of course, with our analysis ability. We don't need a neurologist. In order to diagnose and use it in a clinical setting, what we do have today, we don't have to have a neurologist online, but we do in place, but we do send automatically, the report is sent to a neurologist. It can be in New York, it can be in Israel, it can be anywhere. Goes through the diagnosis, through the report that is generated automatically, gives the diagnosis and evaluation, his remarks, signs it, and send back immediately. So that's the way we use it today.
And there's no risk?
There's no risk, no. There's no risk. Both EEG and TMS have been around forever. TMS by itself, and we do a much smaller version of it, lower frequencies, lower intensities, and by itself a TMS is approved as a 510K without any risk. So we don't have any risk. We never had any risk issues, of course.
Thank you for a very, very exciting presentation. I'll ask the mundane consumer question. You mentioned it's low cost, so we have to take into effect, whether Medicare will pay for it, whether insurance companies will pay for it.
Yeah.
So what represents a low cost?
Yeah, so first of all, this is a commercial question, of course. I refer it, of course, but when we talk about our activity here, We don't talk about anything commercial. It's a research, and we provide the system, and you'll work with the system and publish papers as you like. This is not a commercial site. When you ask about the affordability and accessibility commercially, our business model is built on, there is a reimbursement for the system, first of all. Recently we got the reimbursement from the American Medical Association, of course. So there is a reimbursement, and basically in order to enable physicians to work with it easily, we provide the system and they pay per scan commercially. We're not under research, so they pay only when they use it. We provide the system to enable anyone to use it as easy as possible.
Hi, we have a question from our online audience. They asked, how do EEG brainwave alterations relate to increased hydrocephalic pressure?
The EEG specific or in our system?
I think speaking to your system, yeah.
Yeah, so our system measures the EEG evoked, the brain evoked response using a TMS. So we don't really measure EEG. We do measure EEG. We have those values if they're relevant. But exactly as I showed, we measure the evoked response. So when we evoke a response in NPH patients, we see this EEG, this EKG-like TMS evoked response using Delphi. You see the healthy individuals, and in NPH specific, the signature of NPH patients is a shift of a response to earlier amplitudes. In this case, to the left, you see that the amplitude is like in 80 milliseconds. This is something we see only in NPH patients, and it's very, very predictive and has a very high diagnostic value specifically for NPH. So it's not oscillation of EEG. It's specifically the TMS evoked potential that are measured using Delphi.
I'm going to ask another question if no one else. Oh, Mark? He'll ask a better question.
So I don't want to put words in Sane's mouth, but I think she wants everyone to be brain healthy at age 20, right? The defining decade, I call it. So what's going to be really important is if we start measuring brain health early. We'll give 18 and under a pass. We start at 20. We're going to need to know how sensitive our measures are like this when we do it twice. So if I measure you today and then a year from now, if there's a change, is that meaningful? And also, when we do it once, how sort of meaningful? And that's true for everything. When we take a glucose and someone says you may have prediabetes, it's all a matter of statistics, right? How sensitive it is to change. So can you give us a sense of sort of how sensitive the method is for one person and for 2 points in time?
So obviously, when we submitted the FDA as well, and also in our publication, we had to show the test-retest, the reproducibility of the system. One of the advantages of the system technologically that it's not an EEG, we evoke a response. So again, it's like a very, very robust response. In healthy individuals, it looks almost the same. So again, we do have different features that change between individuals, but we focus on the report on those features that are highly robust and don't change other than age dependent. Of course, if somebody takes a brain-directed drug or underwent some kind of either seizure, mild traumatic brain injury, or traumatic brain injury stroke, we see it very easily. Even if somebody takes SSRI, and we do have a study around the effects of SSRI, antidepressants, anti-anxiety, SNRI, pregabalin drugs, all these drugs affect brain function. So in the short term, acutely, we can see these effects immediately, which is an advantage. If somebody has a test now and will have a test again in a year and nothing happened to his brain significantly that he is aware of, we'll see exactly the same signals. We have a test-retest when we had to prove it to the FDA of about 94%. So it's almost perfect alignment of one signal above the other. It depends when, but even if you do it once a year, you'll see exactly the same signal, and also age-dependent between individuals. Of course, a 20-year-old brain doesn't look like a 70-year-old brain.
And actually, Sandy doesn't want the exact same brain signal. She wants a better brain signal.
Oh, yeah.
Yeah.
So we need to see, we can see an improvement if an improvement happens. Usually, it's very hard to see improvements because there are not many things that improve brain today, of course.
And then in one
Obviously,
person,
hopefully we will see.
And then when you do one person, obviously you're comparing it against a distribution of controls. How sensitive, is it
Between
to say
individuals?
that you're 2 or 3 standard deviations? No, within one person to say you really are an outlier here. What kind of sensitivity have you had for that?
Within one individual, it's very sensitive. As I mentioned, it's over 94% test-retest. So it means even if a different operator in a different hour of the day and different day will have the test, we'll have exactly the same results and plus minus.
Compared to say it's abnormal, what's the sensitivity of saying you're abnormal?
It depends it depends on the specific abnormality. But this part of the work was to establish what is a norm. So we don't only provide a distinction whether he's abnormal, which is very robust, because when somebody is abnormal, we have to show that he is completely abnormal, but we can also show he is within normal range, but almost outside the normal distribution. So the physician who gets the report sees everything. So you might be considered as normal within normal range, but almost on the verge of being abnormal. So you can also follow this, which I think has a lot of value because somebody might be normal now and normal next year, but next year his normality is less normal than evaluated the year before. So you can actually, these measures are go, no go, yes, no, black and white, normal, not normal, healthy, unhealthy, but not only. The actual values are very important here because they change during time. So these two are taken into consideration.
Have you looked at, I was thinking about when you were talking about subjective complaint and the prediction of dementia, but what about people with long COVID or chemo brain or these kinds of other things? Have you used this in that?
Yeah,
what do you predict?
that's a very important question. And we do have a study around chemo brain, which is very interesting. I think it has something to do also with long COVID, but we don't have a study on long COVID today. On chemo brain, we do have a study to actually diagnose those before chemo that will most probably suffer from a cognitive decline following chemotherapy. Today, we know that about 30% of people under chemotherapy suffer from significant cognitive impairment afterwards. You can't really predict who will suffer from it. And I really think, based on our results as well, that we can predict based on the values of brain plasticity, brain connectivity, when they start having the chemotherapy, who will most probably suffer from cognitive abnormality, cognitive decline, and maybe then, if we can detect it, change the course of treatment, the treatment modality in some way that they will suffer from lower cognitive impairment. But I think that's a very, very good question, a very interesting study that we conducted.
Yeah, so Iftach, we have a study right here that Advanvces is doing to look at breast cancer survivors post to see if they can improve with our training. So not just can you predict before they have it, but 5 years afterwards, up to 5 years. So do you think that your measurement might show a change if they're improving?
The advantage again is it's measure that changes both ways. It's not a cognitive assessment that there is a plateau, a ceiling effect, that if you have 100 in cognitive, it's very hard to go above. In physiological measures, you can see both ways.
That's the same as that. So I don't want my brain compared to Mark's. So each of us has our own brain, blueprint, brain print, if you will. How does that fit into this? Because is it me against me, or is it me against? Of course, I'm older than Mark, or me against Mark. I don't want to be compared to him.
That's again a very good question. So it depends on the physiological measurements that we look at. We collect over 50 different measures. The measures that today we present in the report that is generated are specifically, of course, have to be because of FDA, because of everything, because of the clinical utility of the system, they have to have real value. So they compare, your brain to Mark's brain, but you're both within normal range. But specifically using each one's measures, we can also see specific things which are related only to you and follow them. More still on the research side. but still there's a lot to know because it's related to everything. Physiology is everything. If you break down the signal, you can see everything there. Something Mark shows as well, something he won't show it at all. Is it good, is it bad, I'm not sure. But it's something that related only to your brain, and it's based on mainly brain plasticity and your ability to change brain function as required.
So is like the 5-year vision for this to become like standard of care, like in primary care?
Hopefully 5. I mean, these things take longer and it has a lot of, commercial side to it. But at the end, for now, also I think more on the research scientific side, as I see it, and also on the commercial side as a company, the way we see it, we want every center to know that the thing like this exists, and it's part of the discussion around brain health. I think, and I'm sure Professor Chapman and all of you here know it better than I do, when we started almost 10 years ago, nobody talked even about brain health. There is a reason why the trademark for brain health, you own it, because it's something nobody talked about 10 years ago already. And also when we discussed with physicians, everybody said, why should they need it? There's nothing to do with it anyway. Today, everybody understands. 10 years ago, everybody were going to gym for fitness. Nobody took care of their brain. I think today, especially in the medical community, people understand. And it's just getting bigger and bigger. People understand the need to take care of your brain health. And we think that device-wise, we have to be pivot and very central and lead this brain health technology and brain health revolution into the clinical setting, hopefully with your help.
Okay. All right, our time is up. Thank you so much.
Thank you very much.
For sharing and for this really exciting work. Thank you, everybody, for joining us today, and we hope you will join us again in 2 weeks' time on November 17, where we'll be hearing from the Center for Brain Health's very own Dr. Andrew Nevin, who is going to speak about the venture into brainomics. So we hope to see you then. Thank you.